Hello, I'm Ian Pitha. I'm Associate Professor of Ophthalmology at the Wilmer Eye Institute at Johns Hopkins. My presentation today is going to be on glaucoma pathogenesis and screening approaches for glaucoma. These are my disclosures. So first, to give a brief outline of the presentation and present some learning goals, I'd like to at first just establish a basic definition of what glaucoma is and give a basic overview of glaucoma pathogenesis. Then I'll give a really brief introduction on how we diagnose glaucoma, because that will lead into a review of some of the efforts that we've taken towards screening populations so far for glaucoma. So if we look at the basic anatomy of the eye, glaucoma really affects every aspect of the eye, the anterior segment and the posterior segment. Anterior segment is where intraocular pressure is determined, but really when it gets down to defining glaucoma and diagnosing glaucoma, what we look at is the posterior segment, and more specifically, we're looking at the optic nerve head, because that's the site of initial injury in glaucoma, and that's one of the major sites of glaucoma pathogenesis. So we've all seen healthy optic nerve heads. They have a very characteristic structure. You can see where the optic nerve plugged into the back of the eye here, and you can see the blood vessels emanating from it. Every optic nerve head has a rim of healthy tissue, and within that rim is a cup. And in a healthy optic nerve, that cup to rim or cup to disc ratio is generally smaller. And when we look at the function of the nerve fibers that are emanating or entering that optic nerve head, we can see that a person's, and we do that by looking at their visual field tests, we can see that a person's visual field and their peripheral vision is completely intact. So the one spot where there's a physiologic blind spot is where the nerve plugs into the eye. And of course, this is because there are no photoreceptors there. So the blind spot in all of these visual fields corresponds to the location of the optic nerve head. Now, when we're defining glaucoma, there are really two criteria that need to be met. One is there has to be some characteristic structural changes to the optic nerve head. This is most often seen as an enlarged cup to disc ratio and thinning of the healthy optic nerve head rim. This should correspond with a loss of visual function, which in glaucoma, it starts as loss of peripheral vision, and in the early and middle stages is largely asymptomatic. And this can progress to loss of central vision and blurry of vision in the late and end stage stages of glaucoma. And this is when patients often become symptomatic from glaucoma, complaining of blurry vision. Notice when I'm talking about the definition of glaucoma, I did not speak about pressure or intraocular pressure. Now, I'm going to talk about intraocular pressure later, as it is important and very relevant to glaucoma, but it is not intrinsic or is not required to have an elevated intraocular pressure to diagnose glaucoma. So in glaucoma, we have a very characteristic change in the optic nerve head structure that we see in glaucomatous eyes. So on the left side of your screen, you'll see a normal optic nerve head. And you see a cup to disc ratio around 0.3. Around it, you see a very pink and thick rim. You see the blood vessels emanating. And if you look at the retina surrounding the optic nerve head, you can see some striations in that retina. And that corresponds to a healthy nerve fiber layer. Now, if you take that nerve and cut down the length of the optic nerve head, you can see what is shown in panel C here. And that is a healthy, normal optic nerve head going into the optic nerve. And what you see is a relatively flat lamina cribrosa. and you see a healthy nerve fiber layer. The top of that image, just to give you some orientation, is on the inside of the eye, and the dark part or the bottom part of that image is where the myelinated nerve starts. Now, when we start to talk about glaucomatous eyes, there's a very characteristic appearance to this. So in this eye, which has end-stage glaucoma, you can see that the cup to disc ratio is around 0.95. You can barely make out the rim, and you see a deeply excavated cup in panel B. You can't see it in 3 dimensions, but you can certainly imagine how that cup kind of is almost like a bean pot, is how we sometimes describe it. If you look at the area surrounding in the retina, you can see a complete loss of those striations, which means loss of those nerve fiber layers. Now, when we look at this nerve in cross section, it looks very different. And the characteristic finding of glaucoma is excavation. So you can see the cupping or the posterior bowing of that lamina fibrosa, and that is virtually pathognomonic of a diagnosis of glaucoma. Now, if we look at the lamina fibrosa under higher magnification and isolated in postmortem tissue, you can see in panel C, or panel A here, that it looks like a hammock, right? It's a hammock of extracellular collagen tissue. And within each of those holes within the hammock, you have axons going from the retinal ganglion cells in the retina towards the brain. They're not shown in here, but you also have astrocytes in the lamina fibrosa. You have microglial cells, and you have vascular elements as well to supply energy to all of those features. Now, in a normal eye, if you look at it in cross-section, you can see that the lamina fibrosa has a very nice, flat kind of structure. It is like a hammock, but it does have some thickness to it. And if you look at it up close, you can see that there's a very fine, very well-defined ultrastructure to this lamina fibrosa. In glaucomatous eyes, you have excavation. You see this cupping again, and you see our posterior bowing of the lamina. This corresponds with death of axons and vision loss. So these kind of histologic changes are correlated with optic nerve cupping, which is virtually pathognomonic of glaucoma when you see it with visual field changes. So when we make a diagnosis of glaucoma, we have to bring this whole picture together. Structure has to match function. And this set of figures here really nicely illustrates it. In the optic nerve head image on the left side of the screen, you can see that there's a notch in the superior rim. This corresponds with a loss of striations from the retinal nerve fiber layers depicted between the 2 sets of arrows superiorly here. And with that notching of the superior optic nerve head, we see the formation of an inferior arcuate defect. This defect respects the horizontal midline, and the functional loss that we see in this patient matches very well to the superior notch that we see in the optic nerve head. So this is classic early to middle stage glaucoma here. So just to highlight some of those visual field defects that are very characteristic of glaucoma, they respect the horizontal midline. This type of defect is often asymptomatic until it gets to later stages. It doesn't really affect central vision. And these defects usually develop slowly over many, many years. So the patient is able to adapt to these defects without even noticing that they're doing so. Now, in more advanced glaucoma, we see a higher cup to disc ratio. We see a much thinner rim. And looking at this cup, I would predict that the visual field shows superior, which shows superior and inferior peripheral vision loss, and that is what this visual field shows, with the elevated cup to disc ratio, you see a lot more vision loss, and this is much more serious disease in this patient. Now, intraocular pressure is important towards glaucoma. Elevated or higher intraocular pressures elevate the glaucoma risk. It's more common to have glaucoma if you have a higher intraocular pressure. If you have a lower intraocular pressure, that reduces your glaucoma risk. And intraocular pressure is the only modifiable risk factor for glaucoma treatment. So no matter what your pressure is at baseline, if you have glaucoma, the only treatment we have to offer you is to lower that intraocular pressure. But if you look at the graph on the bottom part of the slide, and if you see number of people and their distribution of intraocular pressures, you can see that if you made an arbitrary cutoff of intraocular pressure, let's say 22 millimeters of mercury, you would miss about 50% of people with glaucoma, and you would diagnose about 50% of normals with glaucoma. So just having an arbitrary cutoff for intraocular pressure in our patients with glaucoma misses a lot of glaucoma patients, and also could incorrectly diagnose a lot of our normal patients with glaucoma. So while intraocular pressure is very important towards glaucoma, and as glaucoma providers, we're always thinking about a patient's intraocular pressure, it is not necessary for the diagnosis of glaucoma, and it should not dictate our diagnosis a lot of the times. So when we diagnose glaucoma, we're really assessing structure and function here. We can assess structure by looking at a color picture of the optic nerve head. We have different ways to look at the optic nerve head in more detail and more quantitative ways, such as optic coherence tomography. And then we're assessing function. Now, this is what we do in a perfect world. We can bring everything together to bring about or to clinch a diagnosis of glaucoma. And in this patient that's illustrated here, they have an inferior defect in their optic nerve head, which corresponds with an early supranasal defect on the visual field. But information is not always perfect in the clinic. Sometimes our patients can't perform visual fields. Sometimes we can't get great images to the back of the eye. So sometimes we're working with imperfect details or imperfect information and have to make the diagnosis based on pressure alone if a person is above the 97.5th percentile of pressure for their population. Or sometimes we have to make the diagnosis just by looking at the structure of the nerve. And sometimes we don't know if a patient has glaucoma, and we have to stratify their risk for glaucoma development down the road in the case of ocular hypertensives. So all of this matching of structure and function comes from a basic anatomy of glaucoma damage and the site of damage where the initial insults occur in glaucoma. So in glaucoma, the initial site of damage is thought to be the optic nerve head, and that is damage to the retinal ganglion cells axons, which can be traced back to a specific site in the retina. So in this patient, there's a site of damage in the superior optic nerve head that affected retinal ganglion cells in the superior aspect of the retina. This in turn leads to an inferior arcuate defect that respects the horizontal midline. And so the anatomic location of the retinal ganglion cells that shoot out their axons towards the optic nerve head, therefore dictates the location of the visual field defect, and this is why they usually respect the horizontal midline, or almost always respect the horizontal midline. If we look at optic nerve anatomy, the superior aspect of this, or the superior part of this slide, is the retinal nerve fiber layer in the retina, and you can see the nerve emanating towards the bottom of the screen. Around the optic nerve head and the lamina cribrosa, there is sclera, and the area immediately adjacent to the lamina curvosa is called the peripapillary sclera. And then this leads to the retrolaminal optic nerve head, where myelination occurs, and the axons from our retinal ganglion cells go back to the visual cortex. In acute IOP elevation, it's been shown that anterograde and retrograde axonal transport is slowed down and stopped at the site of the optic nerve head. This has been shown in animal models, and this is an early example of this being shown. See the white and light parts of this image are demonstrate inhibition of anterograde and retrograde transport, which is centered around the lamina curvosa with elevation of pressure in this monkey eye here. This was done experimentally. In chronic glaucoma, the chronic damage leads to cupping and vision loss. And how these chronic changes occur actually isn't completely known. We do know that intraocular pressure stress is translated to the optic nerve head through the sclera through two different mechanisms. One is through hoop stress through the wall of the eye as it kind of goes around through the shell of the eye. And other is translaminar stress, which is the pressure differential from intraocular pressure within the eye to pressure within the nerve tissue outside the eye. So intraocular pressure mechanical stress is one theory of how glaucoma pathogenesis is initiated, and that's supported by slowing down of anterograde and retrograde transport at the axons, showing damage to their function. But glaucoma pathogenesis is likely multifactorial. There is evidence that there's an inflammatory mediators are important in glaucoma pathogenesis. In glaucomatous eyes, it's been shown that there are activated immune cells in the optic nerve head and the retina. And it's not yet clear whether these activated immune cells are beneficial or pathologic in the pathogenesis of glaucoma, but they're a potential target for therapeutic intervention. Now, there's growing evidence that metabolic stress and mitochondrial function damage is involved in glaucoma pathogenesis. Some of the more interesting, more recent papers have looked at vitamin B3 treatment as a neuroprotectant in glaucoma treatment, which targets mitochondrial function. So there have been some short-term studies that have shown that high-dose supplementation with vitamin B3 can actually improve retinal function in glaucomatous eyes. Vascular insufficiency also likely plays a role in glaucoma pathogenesis. This has been shown in a variety of ways using OCT angiography, but also more detailed, more elegant studies in which red blood cells are actually labeled in patients and followed through the many vessels of the retina, which showed alterations in glaucomatous eyes. Now, there's been a lot of interest in the contribution of cerebral spinal fluid pressure towards glaucoma. There's some evidence that it is altered in glaucoma patients, and that it determines, or it has a role in determining the translaminar pressure gradient, which could be important in the progression of glaucoma in some of our patients. Most interestingly, in the past decade or so, we've begun to understand the complex genetic contribution towards glaucoma pathogenesis. So we know that family history is important, with the greatest relative risk increase being in patients with a first-degree relative with glaucoma. We also know that, incidence of Mendelian inheritance and disease-causing single mutations are very rare. But in the past decade, there have been recent studies that have highlighted over 100 single nucleotide polymorphisms, or SNPs, that have been associated with increased risk of glaucoma, increased elevated ocular pressure, and different features of the optic nerve head. So there's a lot of current work that's focusing on determining the significance of these single nucleotide polymorphisms. And there's been some very interesting work more recently on determining a polygenic risk score to risk stratify our patients. So looking at multiple different SNPs in our patients to predetermine what their risk of developing glaucoma is down the road. So there are a number of very interesting possibilities that we could use polygenic risk scores for. The most obvious one is just risk stratifying our patients, being able to look at a cohort of SNPs in a patient and say you are at high risk of developing glaucoma in the next 10 years, or you are at low risk and should be reassured, and having that dictate our clinical follow-up of these patients. But there's also been some very interesting work that shows communication between our polygenic risk scores and other risks of or systemic diseases that have thought to contribute to glaucoma, such as cardiopulmonary diseases and hypertension and diabetes. So we might be able to better understand the link of genetic risk and these different diseases, systemic diseases, towards development of glaucoma. And there's been also some interesting work on certain lifestyle decisions and these polygenic risk scores. So a lot of patients will ask about caffeine consumption in glaucoma and intraocular pressure. And while this has been difficult to show any kind of causal link between them, there might be a possible elevation in intraocular pressure with patients with certain polygenic risk scores as compared to others. So not only could these polygenic risk scores help us potentially better risk stratify our patients, but it could kind of broaden our recommendations to patients in terms of control or surveillance for different diseases or different lifestyle decisions in the future. Now, when we're talking about intraocular pressure, that's determined by the balance of fluid production and drainage within the eye. So fluid is produced in the ciliary body. It goes around the lens through the pupil and drained through the uveoscleral pathway and the trabecular meshwork. In angle closure patients, the drainage through the angle where the trabecular meshwork is inhibited either through formation of chronic scar tissue or through acute angle closure. And our understanding of angle closure glaucoma pathogenesis has increased or grown over the past years as well. We've known that certain anatomic features of the eye, such as a small radius of curvature or short eye, high hyperopes, are at increased risk of angle closure, although many of them escape it. But more recently, we began to understand the genetic contribution of towards angle closure glaucoma and the role of the uveoscleral tissue in creating angle closure events. So one thing that's been shown over the past decade is that usually when irises contract and your pupil expands, the volume of the iris actually decreases in order to create more space, and so the angle isn't crowded. And there's very good evidence now that patients who develop primary angle closure and acute angle closure, when their irises expand and contract, they lose less volume. So the theory is that the angle itself becomes more crowded and more prone to angle closure events. Now, this isn't used in clinical surveillance yet, but it might be used in the future. So there's an argument for glaucoma screening that's very strong. It's a chronic disease that occurs over many, many years, right? It's largely asymptomatic until later stages. So a patient's usually not going to tell you that they have glaucoma until they're in the very late stages, and that's going to be blurring of vision. And we have effective treatments to stop the progression of the disease. Unfortunately, large-scale population screening, it has been difficult to accomplish. Intraocular pressure measurements are not an effective means to screen for glaucoma for the reasons that we've gone over today. And the best way to diagnose glaucoma is to pull together these structural and functional features that we've talked about today. And those testing modalities are very specialized, but they're currently not recommended for population-based screens, although there's an enormous amount of work going on in that. So what should you do when you are seeing a patient and risk assessing them for glaucoma? I'd say do several things. Visualizing the optic nerve head and performing a comprehensive eye exam as patients age and they reach an age where glaucoma could develop is a very important step. Ask about a previous history of glaucoma. It's a lifelong disease, and many times patients are diagnosed earlier in life and then are lost to follow-up and just don't mention it later on until it becomes symptomatic. And ask about a family history. And if your patient has a first-degree relative, especially a sibling with glaucoma or a child with glaucoma, I would recommend screening with a comprehensive eye exam, potentially optic nerve visualization and visual fields. So in conclusion, glaucoma is a diagnosis that's dependent on structural optic nerve head features that match visual field changes. IOP level plays an important role in glaucoma, but it's not an effective metric for glaucoma screening and diagnosis. Glaucoma pathogenesis is really complex and multifactorial, and we're understanding more and more about it from day to day at this point. And personal and family history, along with the comprehensive exams that assess the optic nerve head and potentially assess the peripheral vision, remain the most effective means to screen for glaucoma. Well, I'd like to thank you for your attention today on my presentation on the pathogenesis and screening for glaucoma. Hello, welcome to my presentation on glaucoma, treatment, and sustained delivery systems. My name's Ian Pitha. I'm an associate professor of ophthalmology at the Wilmer Eye Institute at Johns Hopkins. These are my disclosures. So before we get started today, I'll give an overview on what I'd be covering or what I will be covering and present some learning goals for this lecture today. I'd like to give a really brief overview of glaucoma medications and introduce some novel glaucoma medications that have come out in the last several years. I'd like to provide an argument for sustained delivery of glaucoma treatments and why it is going to be the part of the future of glaucoma therapy. And then I'm going to describe 4 different approaches to sustained IOP reduction, and these are in various stages of development, one being FDA approved, some being in clinical development, some being in very early preclinical stages. So this is a timeline of glaucoma medication development. I adapted this from a lecture called The History of Glaucoma Medications by Dr. Wallace Allward. It can be found online, and I would recommend it if you have interest in the history of glaucoma medication development. But you can see that it's really been over a century that we've been developing glaucoma medications, going from cholinergic agonists to more recently the development of Rho kinase inhibitors. And you can see in the last several decades, there's been a lot of development with a lot of new classes of medications that have been given to us as clinicians. So along the line, there's been a lot of benefit that's occurred from really just small and incremental changes to glaucoma medications and the way they're developed. You can see this earlier on. You can see pilocarpine gel took pilocarpine from a 4-time-a-day eye drop and reduced the need or the frequency of that drop administration. And this was also seen with pilocarpine in the development of Ocusert, which was an implant that was placed in the lower fornix of the eye, which allowed several days of delivery of pilocarpine, which is no longer clinically available, but it was certainly appreciated by many patients who were dependent on pilocarpine for intraocular pressure reduction. Now, other things that have happened to build out and incrementally improve our delivery of medications in glaucoma is we built out some of our drug classes. So we've gone from just having one prostaglandin to 3 main types of prostaglandin drugs that we can offer our patients. And we've also developed formulations of our medications that are preservative-free, such as Xioptan, which is a very important type of medication for our patients who are intolerant of preservatives in drops. Now, another way we built out these medications is we've developed combined medications such as dorzolamide and timolol or brimonidine and timolol. And these allow additional IOP reduction without requiring the patient to have multiple eye drops or decrease the eye drop bottle burden of our patients. So along the development of these different of medications in glaucoma over the last 100 years, so it's been kind of marked by major advances, such as the offering of novel drug classes, finding novel targets for IOP reduction, and really large advances in different formulations of some of our drugs. But there's been a lot of clinical improvement that we've seen from some of these incremental advances, such as building out a drug class, developing new drug formulations that allow for better delivery or less frequent delivery of our medications, and creation of different drug combinations. So this is a table demonstrates some of the glaucoma medications that are most frequently used. We have our prostaglandin analogs, beta blockers, alpha agonists such as brimonidine, less frequently used parasympathetomimetic agents, and also we have topical carbonic anhydrase inhibitors. All of these have a characteristic amount of IOP reduction and work by different mechanisms here. And I've used some brackets on the side to show the different combination drops that are available to us, such as dorzolamide and timolol or brimonidine and timolol. But I'd really like to focus on some of the major advances that have happened in the last several years in this presentation. And I'd like to start with describing some of the novel drug classes that have been developed in the past 7 to 10 years. And of the novel targets that we're looking at Rho kinase inhibitors and nitric oxide donors today. So the use of Rho kinase inhibitors to lower intraocular pressure was born from the discovery that targeting the trabecular meshwork cytoskeleton could reduce outflow resistance. Rho kinase is a kinase that's present in trabecular meshwork cells and also throughout the body that has an important role in forming the cytoskeleton of many cells. So by inhibiting the Rho kinase or using a Rho kinase inhibitor here, you can see that the actin filaments go from being very well defined to less defined in these trabecular meshwork cells that have been treated with a Rho kinase inhibitor. And the theory was that by targeting the cytoskeleton, you would open up the trabecular meshwork and therefore reduce the intraocular pressure. In the United States, we have Notarsidil, which is a Rho kinase inhibitor that was examined or trialed in the Rocket 1 and 2 phase 3 clinical trials. And you can see that once a day, Notarsidil really was non-inferior to timolol when given twice a day. So it met its benchmark of being non-inferior to timolol. Unfortunately, Notarsidil was discontinued in about 10% of our Rho kinase inhibitor taking patients and only 2% of timolol treated patients. And the main reason for discontinuation was conjunctival hyperemia and sometimes very dramatic subconjunctival hemorrhages in about 50% of patients. It was also noted that patients had some patients had significant development of corneal verticulata and a whorl keratopathy that was not visually significant, but could be seen under the slit lamp. And that's shown on the left side of the screen here. It can often be quite dramatic, but rarely, if ever, is it visually significant. Now, other corneal changes that are much more rare have been described with Rho kinase inhibitors, such as this honeycomb experience in epithelial edema. that can be seen sometimes with Rho kinase inhibitor administration. And this is visually significant, however, reversible when the Rho kinase inhibitors are stopped. So the other drug I'd like to talk about is latanoprost and notarsidil combination drug. And that was examined in the Mercury 1 and 2 phase 3 clinical trials. It's a fixed combination of notarsidil and latanoprost as separate molecules. And it was shown to be statistically superior in terms of IOP reduction compared to either of these alone as given alone over months. It has a similar side effect profile to notarsidil, but it can offer some additional IOP reduction with a once-a-day eye drop. Lastly, I'd like to talk about latanoprostene bunode, which is examined in the Apollo and Lunar trials. So it is a single molecule that is a nitric oxide donating prostaglandin. It targets the uveal scleral pathway through latanoprost and the trabecular outflow through nitric oxide donation. It has side effects that are similar to the latanoprost. It's largely seen as offering 1 or 2 points of additional IOP reduction as a once-a-day eye drop over latanoprost alone. So if we look at our current glaucoma medications, we can expand this table some. We now have Rho kinase inhibitors, latanoprostene bunode, and a notarsidil latanoprost combination. All of these are once-a-day eye drop timing, so they're very similar to prostaglandin analogs, and they reduce IOP very similarly to other drops, maybe a little better than some of the other once-a-day drops. So if you look at the glaucoma treatment paradigm, this is the way we characteristically have thought about it. You diagnose the patient with glaucoma, you start a drop, and then maybe you need to add some more drops to further reduce their pressure. And once the drops are no longer as effective as you like and the disease is progressing despite the use of drops, you might do a filtering surgery. And once that filtering surgery fails, you might add some drops and do more surgery and then add some more drops and then do more surgery. But in the last 15 years or so, this treatment paradigm has really changed quite significantly. So now when a patient is diagnosed with ocular hypertension or glaucoma, they have a number of different options. One of them is drops, but then, laser treatments such as selective laser trabeculoplasty are also a good early option, as well as MIGS if a patient is going in for cataract surgery. And then the possibilities after that can get very, very complex very quickly in our patients. So the burden or the need for drops to perform better than they traditionally have is greater because we have more options. And the drop limitations, we've known about these for a really long time. Sometimes they don't work as well as we'd like to. Medication adherence is a major issue with a lot of our patients. This has been shown in a number of different ways, but medication adherence can really be horrible, even when we're just asking a patient to use a drop once a day. A lot of our patients are complaining of surface toxicity, and it can be fairly dramatic, and it can cause patients to want to stop these drops, and has led to the development of some and progression of some of these therapeutics, such as laser and MIGS surgery. Some of our drops have systemic side effects, such as lethargy or slowing of the heartbeat. The long-term cost of being on drops over decades and decades can be quite high. And for a lot of our patients, using a drop bottle and actually getting the drop in the eye can be quite difficult. So we can address this in different ways. How can we address poor adherence? Well, we can develop algorithms to identify our poorly adherent patients so we can counsel them further. And we can introduce strategies to remind patients to take their drops. That's been shown to work. But another way to address poor adherence is to develop alternatives to daily drop administration. And this is where we kind of segue into the benefits of sustained delivery. So basically, if you were going to say the benefits of sustained delivery in one sentence, you'd have reduced toxicity, improved efficacy, and you'd remove the need for daily drop adherence. So this graph here shows or illustrates one of the benefits of sustained release or zero order drug release. So when we give an eye drop, here shown as pulse delivery using this hatched line, we have tissue drug concentration on the y-axis and time on the x-axis. When we give an eye drop, we give a very large dose of medication and really try to force it into the eye using a pulse delivery. This means that we're delivering therapeutic levels of medication over a brief period of time in order to get drug within the eye that's within the therapeutic window. Pulse delivery through delivery of therapeutic dosages is more common to have toxicity that's associated with it. And it requires multiple deliveries in order to maintain a patient within the therapeutic window. Now, the concept of controlled release or zero order release is that you deliver the drug, and then because the formulation of your drug is released slowly over time, you're able to have drug levels within the eye that are within the therapeutic window for days, weeks, months, potentially even years, without having therapeutic levels and without requiring repeated administration. So that's really the benefits of controlled release. And all of these benefits kind of go back to these clinical benefits that we're hoping to get with sustained release: to reduce toxicity, improved efficacy, removal of the need for daily drop adherence. There are different ways to deliver drugs. So we're all very familiar with topical administration, which is the way most medications are delivered to the eye. But there are other ways to deliver drugs to the eye, such as subconjunctival administration and intravitreal administration. Once you start introducing needles into our administration, patients might become a little less eager to undergo those procedures in order to deliver their drugs. And then we also have implants that are used not for the treatment of glaucoma, but we certainly have steroid implants that are used to treat retinal diseases as well, that are injected within the eye. So if you look at the development of sustained release formulations in glaucoma, there's really a whole cohort of companies and groups that are interested in this approach. This figure illustrates a few of these. It's by no means a complete list of the different approaches that are being taken, but they run the gamut from small implants that are injected into the intracameral space, implants that are placed within the trabecular meshwork, and implants that are placed within the canalicular system or placed within the fornices. Other approaches that are being taken are contact lenses as well. And intravitreal injections have been attempted as well. So if you talk to patients, I think they're very eager to find drop alternatives. Many patients would be likely or very likely to accept a delivery method or of a medication that eliminated the need for them to take daily eye drops. And they'd be willing to undergo subconjunctival injections or injections within the eye, depending upon the length of the duration of that drug effect and how well it worked. So the only FDA-approved or currently FDA-approved sustained delivery medication for glaucoma treatment is the intracameral sustained release formulation of bimatoprost. It delivers 10 micrograms of bimatoprost over approximately 4 months. And interestingly, 10 micrograms of bimatoprost is roughly the amount of medication that you would have in one eye drop. It's an intracameral implant, so it's placed within the intracameral space. And you can see it on the head of a dime here. And there's an injector system that we use to inject it within the eye. And then it floats down into the inferior angle and stays there. The theory is that it's delivering drugs into the intracameral space right to the target. So it reduces periorbital drug exposure while delivering a really very therapeutic dosage of medication to the target tissue, which is the uveoscleral pathway. And this has been shown in animal studies, right? So you see an elevated dosage of the bimatoprost with the implant and the iris and ciliary body compared to bimatoprost drops. And this is log orders higher than the delivery or the levels that we get with using a bimatoprost drop. With this higher dosage of bimatoprost that's delivered to the target tissue, there's a lot of interest in possible alternative mechanisms of action due to this distribution, and we might get a prolonged effect with this that has been suggested in some of the clinical trials on the bimatoprost implant. With the elevated dosage at the target tissue, you get a reduced dosage in the eyelids and orbit. This is shown in this figure here. So you can see with topical bimatoprost that's given, you have much higher doses in the bulbar conj and the eyelids and the periorbital fat compared to the bimatoprost implant. And this could have relevance to side effects of bimatoprost, such as periorbital fat atrophy and eyelid darkening as well. So the bimatoprost implant was evaluated in 2 stage 3 or clinical studies. The 10 microgram dose met its endpoint of non-inferiority to timolol through 12 weeks. There was some phase 1 and phase 2, as well as phase 3 evidence of a prolonged IOP reduction in some patients after the drug release was complete. So after the 12 weeks was completed, some patients had a prolonged IOP lowering effect and did not require restarting of the eye drop. One caveat to this and one toxicity from the bimatoprost implant was that 8.1% of the patients experienced a greater than 20% reduction in the corneal endothelial cell loss at 20 months. So after 3 injections, this was despite choosing angles in which we thought, or they thought, that the bimatoprost implant would not be touching the cornea. So the bimatoprost implant is currently FDA approved for a single injection only in our patients. Another approach that's in phase 3 clinical exams but not currently FDA approved is the iDose, which is a travoprost implant, delivers 78 micrograms, and unlike the bimatoprost sustained release implant, it is secured within the trabecular meshwork, much like an eye stent is. It's placed in the operating room and is secured anatomically within the eye. The targeted duration of release in this formulation is 6 to 12 months. You can see it illustrated here in the angle, and you can actually, in this image shown here, see it from a slit lamp exam at roughly the 2 o'clock position in this picture. So it's currently in phase 3 studies. There are no peer-reviewed publications out on its efficacy. But in releases from the company, it did show significant IOP reduction through at least 9 months. Again, the target duration of release for this implant was 6 to 12 months. Placed in the operating room is secured anatomically within the eye. In phase 2 clinical studies, this is a different approach that was taken. It's the bimatoprost ocular insert, which is a ring that is placed within the fornix by a provider. And you can actually see it kind of goes, it's a ring that sits in the upper and lower fornices, and you can see that once it sits in there, you can see one aspect of it, but the rest of the implant is just under the fornices and in place. Its target release was over 6 months, and it was evaluated in a phase 2 study. Its IOP reduction met non-inferiority definition at 2 of the 9 time points that they checked. It was really tolerated very well by patients, and unlike a lot of contact lenses, it had excellent insert retention over the duration of the study. It is currently still in clinical development, but the most recent clinical study was in phase 2. And now if we go on to kind of more theoretical ways to permanently reduce the IOP in a sustained way, and this is all preclinical studies. We know certain genetic alterations are associated with elevated IOP, such as a myocilin gene. By knocking out the myocilin gene using an adenoviral vector, you can get prolonged IOP reduction in mouse models of glaucoma. Whether and when this comes to clinical use, it has yet to be determined. But it's another approach besides drug delivery as we begin to understand the genetic contributions towards elevated IOP. The possibility of a personalized approach towards permanent IOP reduction in our eyes is possible. So in conclusion, there's still significant room for further development of new IOP reducing agents. However, it seems like the price of admission for new drugs is daily administration or less frequent because our patients aren't going to tolerate that, and we have evidence of non-adherence in a lot of our more frequent drops. Bimatoprost implant is currently clinically approved for one-time intracameral injection. And there are a number of alternative delivery methods for prostaglandins that are currently being developed. There are some future approaches that could offer a more permanent IOP reduction through genetics, but those are all in preclinical stages at this point. I'd like to thank you for your attention on this presentation of glaucoma treatments and sustained release of medications.